Okay, Dr. Evan Parks, so glad to have you on the show. I appreciate you being here and appreciate your time to just come and record and podcast with me.
Brandon, it is a privilege to be here with you today.
So, Evan, you've got a work that you're doing as a doctor, and you're working at a
hmm
hospital right now.
Yeah,
But what kind of doctor are you? Tell us a little bit about what kind of work you do.
sure. I am a clinical psychologist and I work here in Grand Rapids, Michigan. And the kind of hospital that I work in is specialized. It is called Mary Free Bed Rehabilitation Hospital. And there is an inpatient side of the work that we do where we have many of the accident victims that uh, are here in Michigan. About 70% of all long-term car accident victims end up in our hospital for rehabilitation, stroke, head injury, spine, amputation, a lot of things like that. But we also have a outpatient side, many different outpatient clinics, and I work in a specialized outpatient clinic that is really just focused on chronic pain. And we have a 10-week program where people who have had chronic pain, often for a number of years, are coming here to get help, to get moving again, to get off of medications that they have been on, often to manage their chronic pain, and to learn how to do the kinds of things that they used to be doing before that onset of chronic pain.
Hmm. I'm really excited to hear a lot of your perspective specifically because I've had many other people on the podcast so far who have been working in different fields, and I haven't quite gotten into your field in coming to the podcast. So I'm really excited to hear some of the new things
Good,
you're going to be sharing. I know I'm going to
good.
be learning a lot, and we're going to be bringing a lot of new things to the table for people. Before we dive into that, I do just want to ask, working at a hospital, how has your work been changed and affected right now by the COVID-19 outbreak?
Yes, very significantly, it's been changed. The last week, 10 days, we have shifted all of our outpatient services to be conducted over telehealth. Basically, I have an account um, with this hospital approved, HIPAA approved program that allows me to talk with patients in their home.
Oh, great.
And we are able to basically video conference call them. And some of the people that we are doing that with are brand new into our program. They're just starting this week. And so that includes video conference calls, not only between the psychologist and the patient, the occupational therapist, the physical therapist, the nurse, and the physician that is looking after their physical health and their medications. So it's a very different way. We have a hands-on approach, and now we're rethinking, retooling everything that we do in
Hmm.
order to continue to meet the needs of people who have chronic pain and need help.
Hmm. Okay, that's great that you guys are able to do some of that telemedicine. I know that a lot of people are moving that direction, and it's a big shift for everybody. So that's great that you guys are getting on board with that and still helping people.
Yes. Yeah, and it's an adjustment for the people that we were seeing here in the clinic on an outpatient basis. Um, and honestly, some people are happy for the opportunity to continue, and some people are questioning whether or not they want to do telehealth and would rather wait for us to, reopen our doors to, seeing people in person. And we understand that.
Hmm.
Telehealth is an option. It's just not an option for everyone.
Right, right. Totally understand that. Yeah. Well, I'd love to hear what kind of brought you into your work and your
hmm
approach. I know that you've got an interesting story of how you learned a lot of these things, and I'd love to hear where that began for you and how you got to the
Sure.
place you're at right now.
Okay. Excellent. I am going to start back in my college days, if that's not too far back,
No,
quite a
please
few
do.
years ago, quite a few years ago. But what really interested me in psychology as a field was I was overseas. I was doing a study abroad program, and I was living with a host family. And the host family that I was living with seemed to be going through some struggles and stress, um, in part because of situations that they were in with their work. And I was just like a fly on the wall, you might say, observing, noticing. And I came back from that experience of living overseas really interested in how people deal with stress
Hmm.
and what happens to people when they are under stress, emotionally, physically, relationally. And a friend of mine suggested, hey, why don't you take a psychology class? That might be up your alley. So I did. And, the rest is history.
Hmm.
And so, what led then to me really diving into the work that I'm passionate about, was that cross cultural experience. And after I went through graduate school and started my work as a psychologist, still working here in Michigan, I had opportunities to travel overseas to start uh, offering lectures to humanitarian groups and mission organizations and NGOs, where their people who are serving cross culturally are under stress, and they wanted me to come give them some tools.
That's
Um,
great.
and, and that was exciting and interesting. Really got to see firsthand how difficult life is for individuals, couples, families, kids, parenting, all of that. And then what came to mind while I was traveling is, wow, it would be good if there would be a opportunity for people who are overseas to get help overseas. And there was interest in an organization to back that. So I connected with them, and my wife and I, and at that time, our 3-year-old daughter, we moved to Budapest, Hungary, and we set up in downtown Budapest a beautiful center for people who were basically doing cross-cultural work all across the Soviet, former Soviet states, Middle East, Central Asia, and Eastern Europe, to be able to come there when there was a mental health need. And when they weren't able to come, I would travel to many, many different places and countries to be able to work on site. Somebody might have been traumatized by home invasion. That was very common when we were there, especially in the former Soviet states and Russia.
Hmm.
Um, and Abuse even within homes of people who are working, uh, emotional, physical breakdown, people becoming depressed, or people coming overseas. This isn't very good, but it does happen, coming overseas with pre-existing mental health problems, and those mental health problems get much worse,
Hmm.
under the context of the work that they're doing. So that really got me into a lot of uh, work within the Hungarian culture where we were at, because I saw a need for people to have access to mental health care. So, just to give you a little background of Hungary, up until 1989, it was a part of the former Soviet Empire. Mental health services were only really for people who had schizophrenia,
Hmm.
something like that. The average person didn't talk about their problems. Hungary has extremely high, one of the highest in the world, suicide rates.
Wow.
So there's a lot of alcoholism, a lot of depression, and I just thought, there really needs to be a way to reach the public. People aren't going to show up and talk to a psychologist. There's just too
Hmm.
much stigma and taboo. So I started contacting community centers, colleges, schools, um, universities and offering talks on, what does it mean to be mentally healthy? What does it mean to have depression, and you can still be okay if
Mhm.
you have depression. It's not a horrible thing, and it really took off. Um, and one of the things that I thought was the most rewarding for me was to talk to groups of doctors, physicians, nurses, and I would talk about a mind-body relationship. And really, it was new information. They had never heard that, apart from biology, that there is anything to consider,
Mm,
in terms of people's health and mental health. So I just, outlined really basic concepts of how stress impacts, how thinking impacts, how our relationships impact our life, and I mean, it opened up new ways for those healthcare providers to be helping the people that they were working with. So that was super, super rewarding.
yeah, and before I know you got a lot more to say, before we move on from Hungry here, first of all, that sounds like a great organization that was going in and doing that. What awesome
Yeah.
people you were working with. That's great. And second, I've got a good longtime friend, childhood friend of mine, and he's Hungarian, and his
Oh.
grandma fled from Hungary during that time,
Mm.
and I think she was just in high school. I can't remember exactly how old she was, but she was,
1956,
yeah,
probably.
yeah, she was young, and she told me all kinds of stories of just how terrible it was there. And her mom just fled and came here to the
Hmm.
west coast of the United States, and she made her life here. But I can understand how it was a terrible time, and it's left
Mm.
obviously some long-term scars in the country. So that's great that you
Right.
were able to go there and help those people like that. Yeah,
Yes. Yeah.
yeah,
Well, thank you very much. Yeah. I
yeah.
mean, I have come across many Hungarians here in the United States, who fled either in 1956 with this failed revolution that they tried in October of that year, or later.
Mm.
Right up until 1989. I mean, people were still sneaking out if they could get there.
Right, right. That was a powerful thing that you said a second ago, talking about how people didn't want to talk to you because you were a psychologist, and they didn't really like that label or wanting to come see you,
Yeah.
and you wanting to help them understand that having something like depression or anxiety, they don't have to think of themselves as being abnormal. Like, they don't have to think of
Right.
themselves differently in that sense. That's a
Hmm.
really powerful thing to say, because I think that a lot of people do have kind of a shaming or an
Hmm.
embarrassment if they have something going on emotionally, which it's like everybody has something going on emotionally. We
Yes.
can
Yeah.
all be open to that and talk about it.
Right.
We don't have to,
Right.
slide it under the rug or put it in the closet or anything. And so I think
Right.
that's really important point that you were trying to create an acceptance for people.
Mm.
They're like, hey,
Hmm.
this is what's happening in your life, and you don't have to think of it as wrong or bad. Just accept it. And how can we grow and move on from that? I mean, that's a powerful thing for a lot of people, I think.
You,
I
absolutely.
Oh yeah, yeah. I would love to talk about some of the pain conditions specifically you are helping people with through understanding the psychology and your approach in working with people. I mean, somebody you were talking about with the hospital that you're working at now, people get in car accidents, and then you're
Hmm.
helping them with the chronic pain. What exactly is the chronic pain that you're helping people with?
Great question. We have different categories of chronic pain people coming. Uh, the most common, according to some of the studies that we've done looking at our patient population, are people who come with what we call multiple site pain. And you would see this yourself in your own practice. You find somebody who has at one point had degenerative, neck issues, so they have had maybe, a surgery or two on their neck, but that's not all. They had lower back problems at another time, and they have lower back issues and maybe a lower back surgery, and then their shoulder goes out, and they have shoulder problems and their
Yep.
knee is a problem. So it's not like they have one thing. They have what we call multiple site pain, and add on to that a headache or migraines, and that's really probably it is the most common type of person that we have coming into our program. And so they feel often quite discouraged because they get different kinds of advice for each body area and different medications and failed surgeries and injections and stimulator devices and all of these things. And they're like, well, I'm beyond hope.
Hmm.
So we don't believe that at all. We have an approach, and we're gonna hopefully outline some of that while we're talking. The second most common is fibromyalgia.
Mhm.
So it is also technically multiple site pain, but it's of a different origin. There isn't a specific neck injury or lower back injury or shoulder injury that leads to the onset of fibromyalgia. It might start with that, but really what's characteristic of fibromyalgia is they have widespread pain. And what I mean by that is head to toe. They have sensitivity to the touch, and they have painful, very specific spots or points, pain points throughout their body. They have fatigue and sleep disturbance and quite a number of things. So that would probably be our second most common category. And then we have cervical, probably the neck is right up there, with a very common area, as well as the low back, and then headaches, migraines. And then since we are a specialized clinic, we probably see far more people who have a less common condition called chronic regional pain syndrome.
Hmm.
And so there are, in our patient population, we have quite a number of individuals with that. And what that it's often after a crush injury, a very specific kind of injury. They have maybe been in a factory and a press has come down on their arm,
Hmm.
or they've been in a car accident where they have multiple broken bones in their foot, ankle, lower leg, and then after the normal healing process, what develops is this extremely intense sensitivity to anything. So somebody who has CRPS, maybe in a foot, they come in without a sock, without a shoe, without a pant on, only shorts. Even if it's winter and it's minus 15 degrees, they really cannot tolerate any contact with that area of their body. So we see quite a few people like that and are able to help them.
Hmm. Now, you're seeing people who I'm assuming this is the context. It sounds like this, but you're seeing people who have had an acute injury. You were talking about like a press falling on someone's
Right.
arm and hurting them.
Hmm.
Um, how does psychology connect with that? They're having a physical damage, and
Sure.
then it's translating into a chronic pain. And then
Hmm.
how are you coming in with psychology? How is that working for them?
Okay. So, Brandon, your question is a question that is running through every patient's mind who comes into my office.
Mhm.
They're
Yeah.
like, I've got a physical problem here. Why am I talking to a psychologist?
Hmm.
And whether they say it out loud or not, I know that they're thinking it. So,
Because you're a
we try.
psychologist, of course you know what they're thinking.
Yeah. So, one of the things that we start off with, and I focus on, is a little explanation into what is chronic pain. And the explanation that I give really emphasizes the role of the mind. And that expands kind of the picture that a person has of what's involved with pain. So by the end of this explanation that we give them. And each discipline, occupational therapy, physical therapy, medicine, nursing, we're all giving them the same kind of uh, what we call pain education or neuroscience education. And so they get this message reinforced several times. And by the time that they've heard it a few times, they go, okay, um, there's a mind body connection here that I wasn't factoring in. And the psychology part of that is where we're going to do a lot of the work. How pain is viewed, how the brain gets rewired, why strategies like acceptance or breathing exercises or mindfulness, as simple as they are, actually have huge impact on how the brain processes that sensory information. And so, I'm upfront with people as they sit down and talk with me. I say, you might not be sure why you're meeting with a psychologist, and I want to share some things with you. And by the time I'm done sharing this, I want you to, tell me real honestly what you're thinking about working with a psychologist. And people, by the time they hear this pain education, they go, oh, well, maybe there's something I can learn, you know, and I really want them to be able to see themselves in the pain education that we give, so that it doesn't feel like I'm describing somebody else that, might benefit from our approach.
Hmm.
I want them to be able to see themselves that, like, oh yeah, you're describing the kind of reactions I've had, the kind of stress that I've had, the kind of symptoms that I've had, the treatments that I have had. And you know m- and if I can plant maybe a seed of doubt that the things that they've done haven't worked for a reason, and maybe the way that they were thinking about it might not be the right way. If that doubt, you know is planted a little bit, it just kind of opens the door to, well, maybe there's another way.
Hmm. Now, you're talking about how a lot of different practitioners are coming together to give them their pain education.
Yeah.
In the hospital, I'm assuming that you're working with like teams of people.
Mhm.
What other people are you working with in trying to solve the chronic pain that people have? Like you're coming from the psychology approach.
Yeah.
Is
Hmm.
everybody working in the psychology, or do you have people doing other treatments or things with them as
Yeah.
well?
Yeah, we sure do. So, a big part of our pain education is helping a person understand that the brain has this way of analyzing the sensory input that it gets. And so, the typical way that we think about pain is that if I have a straight pin and I poke my finger, I picture there's a nerve at the end of my finger that says ouch. And this nerve signal travels to my spine up to my brain, and my brain goes, oh, my finger is hurt. And we say, well, that's actually a misconception. What we picture happening is that when you have a straight pin and you poke your finger, there's that nerve ending. That nerve ending says, hey, something has changed. And that change signal goes to the spine up to the brain, and the brain then has to evaluate that. Is that a threat or is that not a threat? And if the brain says, yes, that's a threat, it will produce pain. And so, with this real basic model, what we are looking at is that pain is not an input, it's an output.
Hmm.
And the brain itself is doing this analysis. And maybe the way the brain is analyzing information in the situation of chronic pain might not be based on complete information or inaccurate information. And that's where hope comes, because we can, number one, begin to understand how the brain is analyzing that information, and we can begin to tweak it. And And so one of the ways that we begin to tweak it is to introduce this really simple idea that pain does not equal harm.
Hmm.
So we generally think that if it hurts, I'm doing damage. And that's not always the case. So a person who has pain, they're resistant to movement in part because they feel that if I do move, I'm obviously doing something bad to myself. And so if we then listen to the brain's advice, the rules that the brain comes up with, the brain basically wants to move us toward a room that we can shut the door, make dark, stay there,
Right.
you know,
Yeah.
and eliminate all sensory input, to reduce our short-term pain. But
Hmm.
that rule interferes with our body's ability to heal. And so this new mindset that we want, to take hold is pain does not actually equal harm. And that's where the physical therapy and occupational therapy massage comes in. Because getting that person moving again is going to be critical to their long-term recovery.
Hmm.
And so what we try to do with the occupational physical therapy and other kind of activities that we get them involved in is try to get them moving in a safe way that's just approaching that pain threshold, but not going too far into that zone. And then stopping, resting, recovering, and then re-engaging, and then going again.
Hmm.
So the concept of pacing. Pacing is
Right.
really hard for people to buy into, in part because they've got a lot to do.
Hmm.
I can't break up the vacuuming in my house. I got a big house. Well, you have a choice. It's you vacuum all at once and then you be flared up for the next 5 days, or you vacuum in 5-minute increments and you take a few minute break in between, and it takes you quite a bit longer, but you don't get flared up. But while you're doing that, you're really reconditioning your brain not to associate that activity with pain.
Hmm. Yeah, that choice is so important, and I feel like I'm preaching that message to my clients on a regular basis.
Yes.
They need to choose what they're going to do with their body, what they're going
Hmm.
to do with their pain, how they're going to view their body, how they're going to
Right.
interact, and how they're going to train their body. You know,
Yeah.
how are you
Right.
going to teach yourself, something new or unlearn something that your body has learned?
Hmm.
That's a choice that each person makes, and
Hmm.
it can be confusing for people, so it's great that you're educating them on that. And
Hmm.
it can be a really difficult choice because it is a lifestyle change that people have to make, and so that
Yeah.
can be really hard for a lot of people.
It is. It is.
Yeah.
Yeah.
Now you also have a podcast. You also
I
have a
do.
podcast, and you lead people through a lot of maybe tweaking,
Hmm.
little exercises and things that people can do. I'd love to hear more about what you do on your podcast.
Yeah. Thank you. The podcast is called Pain Rehab Podcast. Real simple name. And it's on iTunes and other places. But the focus of what I do in my sessions with patients many times is giving them a tool of, hey, how do you look at pain differently? How do you calm down your nervous system? How do you engage in noticing without evaluating or judging or trying to change what you're noticing, which is basically the concept of mindfulness. And I have heard from so many people over the course of my time talking with them and teaching them in session, practicing in session, and then they go home and they try to practice and they come back and they say, well, I couldn't quite remember what you said. So I thought, well, I can solve that. So
Hmm.
that's where the podcast idea came from, is just giving that tool of how do you do that breathing exercise, how do you do that body scan, how do you visualize things or physicalize pain? How do you do progressive muscle relaxation? Basically, I just recorded myself like I would be talking to somebody that's in my office. And so the podcasts are relatively short, anywhere from 8 to 10 minutes. And as I have opportunity, I haven't quite been able to get into a sync of each week, releasing the next one. I would like to get to that point because I have quite a few all lined up, that I want to record. There are just so many good exercises that people can do, and I'm learning from the people that I'm sharing these with, because as people begin to practice, I'm hearing from many people what is really helpful, and what is less helpful. So I really want to get those more helpful things out, and so that's where the idea came from. And so it's really focused on putting on a pair of headphones, earbuds, getting in a comfortable position, laying flat on your back, being in a recliner,
Hmm.
and listening for 10 minutes. And so many of the exercises that I have people do, I try to get them to do it at least twice a day, usually in the AM hours and in the PM hours, just to be able to have this interruption in the press of their day, so that they get more aware of their body and more aware of how busy their mind is.
Hmm.
You know, as soon as I do a breathing exercise, just a diaphragmatic breathing exercise with anyone that comes into my office, and I set it up, I explain all the steps. As soon as I start it, I cannot believe how noisy my head is.
Hmm.
It's really hard to focus my attention, and I'm doing this every day. And, but I mean, it's really instructive for people to understand that our brains are noisy and we,
Yeah.
get carried away with that noise. And doing some of these things really helps to slow down our uh, our sympathetic nervous system, engage the parasympathetic system so that, we have this break on our acceleration, that we're getting caught up with. You get in the car, you turn on the news, your blood pressure goes up, you
Right.
know.
Yep. Yeah, and the monkey brain going all over the place
Yeah.
is, I mean, that's widespread. Everybody's getting that these days.
Yes.
You remind me, there's so many things you brought up that I want to talk about. You remind me of several things. I've recently been really trying to engage myself in practicing silence.
Hmm.
Instead of a long day of work, you feel stressed, your mind is going. You oftentimes hear that phrase, I just want to go home and do nothing. And then
Hmm.
we go home and we watch Netflix, or we go home and we do something. We don't do nothing. We do things.
Right.
And I've been challenging myself, okay, when I feel that way, when I have that mindset of I just don't want to do anything right now. You need that's a
Hmm.
signal. I need to listen to myself. I need to actually do nothing. I'm going to go maybe sit down in a chair, exactly what you're saying, take some breaths. Maybe I'll just look out the window and I'm just going to be silent. I'm not going to
Hmm.
engage in anything necessarily. I'm just going to enjoy the present moment that I'm in.
Hmm.
Um, I Another story, kind of along that same line of thought. I recently was watching that new movie by Fred Rogers, or about Fred
Hmm.
Rogers, Mr.
Sure.
Rogers.
Hmm.
And let's, if I'm going to watch a movie, let me watch something that's calming and kind of going along with
Uplifting.
uplifting. And after that movie, I felt I felt like I could just sit and look into somebody's eyes. I had
Hmm.
kind of the impression of Mr. Rogers on me that, like, oh, I'm just going to sit and look at this person and listen to him. And I just felt so calm that I could do that.
Hmm.
And I think I think that's a skill. It sounds like something that, you just sit there and you do nothing, right? Like, it sounds like something that, is really easy to do, but it's not. It's
Right.
challenging. You got to
It.
learn how to do that. Yeah.
Yeah.
Um, And so I think that's great that you're helping people do that on the podcast. You're helping people do that with the meditation, the breathing. I would like to clarify one thing that you were
Hmm.
saying. You're talking about visualization, and I'd love
Yeah.
to know more about that because when I talk to people about visualization, I hear people throw around all kinds of different things. And I know that
Hmm.
there's, a therapeutic form of visualization. There's other people who have this idea that it's a very new age spiritual
Hmm.
concept. There's a lot of different ideas behind visualization. I'd love to know what your perspective and how you're doing visualization.
Sure. This approach that I use comes out of a therapy style that we use here in our program. So all the psychologists are using an approach called acceptance and commitment therapy, and the abbreviation for that is ACT therapy. And so there is this perspective in ACT that we get hooked by the things that show up in our mind. And one of the strategies of ACT is to learn how to recognize, number one, that we're getting hooked all the time by our thoughts, our emotions, our sensations, our memories, our self judgments. We treat them as true, we treat them as important, and we get carried along often in directions that we don't want to go when we buy into all of that stuff. And so when you take that approach of ACT and learning how to notice things, learning how to disconnect from things, it has a lot of application when you think about pain. When pain shows up, it shows up with all kinds of things that go with it. This is terrible. It's ruining my life. It's in control. It's in charge. It's in the driver's seat. I'm not in control. Pain is in control. This isn't fair. Why does this happen to me? And this is only going to get worse. I'm going to go from limping to a wheelchair to, being unable to move. I'm going to lose my job. You can just hear all the things that get networked into uh, the sensation that
Mm,
we call pain. And so, with patients, what I'll do is I'll ask them, what shows up when pain, is present in your life, and they'll tell me, some of these things. It's my fault. It's not fair. All the mental activity that I just mentioned. And so, what the approach is that we use is to try to help a person de-identify with the thing that they're struggling with. And a simple way to explain that is there's a huge difference between the statement, I am anxious, and I notice that I have anxiety in my chest.
hmm.
That first statement is identity. The second statement is it's a sensation that I have, but it's not who I am.
Right.
So we identify with the stuff often that shows up. And a way of helping a person de identify with pain is to get them to visualize it as a physical thing. So I'll walk you through some of the basics. So
Yeah,
what
please
I'll
do.
what I'll have a person do is say, have them close their eyes and say, all right, I'd like you to picture the pain that you have as something that is now manifesting itself in front of you. It just kind of left your hip, it left your lower back, it left your head. Now it's like out there in front of you. Uh, if that were to happen, what shape would it have? What size would it be? What kind of movements would it make? What color would it be? If it were a cartoon character, what would it look like? If it were a monster, what shape would it have? And So depending on the person, there are, they have their own way of, you know, conceptualizing. Nobody does it really the same way. Um, what kind of sounds would it make? Just it really doesn't matter. What specific things I'm asking them to visualize. What those questions do is just kind of give it some kind of form, some kind of structure. Then what I'll have them do is imagine that this shape becomes bigger and then smaller and changes colors. What they're doing really in their own mind is manipulating a sensation that they're having, but they don't realize that they're doing it while they're doing it because they're really just more
Mm,
focused on that sensation or on that, the words of the visualization. And
mm,
then in the end, what I ask them to do is to invite that thing that they have visualized back into their life, but to do it almost in a way that they are creating a space for it to be,
mm,
and then surrounding it with a breath. So I'll have them picture that it comes back into some area of their body, and that I have them breathe deeply and say, just picture that air surrounding, enveloping, welcoming, holding that there. And what generally happens, Brandon, is that a person not only de-identifies themselves with that pain, but that pain becomes much more localized to that one spot. It's
mm.
contained.
Yeah.
And so that really becomes a powerful exercise. And it works exactly the same if you were to substitute pain for anxiety
Mm,
or depression
yeah.
or the thought, I am a loser, I am inadequate,
Mm,
the shame based thoughts that we like to carry around.
yeah. That's that's really amazing how easy, or at least you make it sound easy, but
Okay.
how simple it sounds to give someone control of their pain,
Yeah.
because that is something people always feel like they're in this prison by their pain. And you
Right.
basically showed them, take that pain out of your body, like you
Right.
were saying, take it away from yourself. And now you manipulate, now you change it however you want, like you're the
Hmm.
one who's in control of that pain. Now put it back. I mean, that's wow. That's a really great form of visualization. That wasn't what I was thinking you were going to say when you were saying
Uh-huh.
visualization.
Yeah.
I was thinking you were going to say something like, imagine yourself lying on a beach and you're listening to the sounds of the ocean or
Uh-huh.
something. I thought you
Yeah.
were going to say something different. So I really like how constructive and how focused and purposeful that is to the specific perception of pain that people have. That's really, really cool. I like that a lot.
Yeah. So, Brandon, one of the neat things about ACT, acceptance and commitment therapy, is that it doesn't try to control pain or anxiety, and
Hmm.
in fact sees that as counterproductive. So, one of the things that we generally want to do when we have some kind of distress is to reduce that distress. Um, and we don't recognize the power of accepting that distress as a very effective tool in reducing it.
Hmm.
So as we move towards something with openness and willingness, it has less power over us.
So you're thinking, you know, back to the idea of control here, when we're
Mhm.
talking about having control over pain, um, how are we defining control here? Like
Uh-huh.
the ability to let go, because obviously pain is a signal we need to have in our body. If
Mhm.
a big press falls on your arm and crushes it and you don't feel any pain from that, you're not going to understand that, you've been injured, or if you prick your
Right.
finger and you don't feel pain,
Mhm.
you're not going to realize that, oh, I damaged myself here, and I need
Right,
to I
right,
need to
right.
get
Yeah,
away
right.
from whatever that thing was, right? Pain is a really healthy, good response we need to have. So when we talk about controlling pain or not controlling pain, what is it? Expound on that for me. What is it that you're
Yeah.
thinking of?
Yeah, I'll use a visual that I like, because most people have experienced something like this, or at least seen this. So picture on the front porch of somebody's house a German Shepherd or a Rottweiler, a dog that basically is tough, territorial, and an alpha.
Okay, yeah,
It's not a golden retriever. You
right.
know, it's a very, very specific kind of watchful dog. So
Okay.
a stranger walks up to this house with this German Shepherd sitting on the front porch. And as the stranger approaches the dog is asking itself this very basic question: is this person allowed to be here? Do I need to do something about that? If it were a golden retriever, the golden retriever would be saying, "Oh, is this a friend?"
Hmm.
you know, Very different outlook of golden retriever, but German Shepherd's not going to be asking itself that.
Hmm.
And so the way that I think about control that's negative is if a person says to themselves, "Oh no, how do I avoid this dog? This dog is a threat. Um, and I have to be very careful because I don't want to get hurt by this dog. So how am I going to manage that?"
Hmm.
Well, somehow a German Shepherd is able to read that, and it knows instinctively that that dog is in control and that person approaching it is not.
Hmm.
Now picture someone who understands dog psychology, and they say to themselves, I am not going to look at that dog. I'm not going to pay attention to anything that that dog is. I am in charge. And as I approach this dog is going to mean nothing to me.
Hmm.
And if you've ever seen any of the broadcasts of Caesar Milan, the dog whisperer, the guy who
I,
trains dogs,
just a little bit. Yeah, I know who you're talking about.
yeah. So as he would approach an out of control dog, these dogs come, scampering over to him and sit at his feet. And the owners are always like, "Well, what did you just do?" He goes, "They know I'm in charge."
Hmm.
So when we approach pain with fear, and a desire to try to control it, what I picture happening is that fear and pain ultimately get the upper hand and we lose. But if we approach pain with this sense of, um, what can you do to me? You're there, I'm here. You're not in charge, I'm in charge. Um, and I'm going to move toward you with openness, curiosity, and willingness. And almost explore you as if I were an alien exploring something that is completely unknown.
Hmm.
When we do that, something changes in our brain. And this is central to this analysis that I was talking about that's happening. Our brain is always weighing things that it experiences. Is there evidence for danger, or is there evidence for safety? And
Hmm.
when the evidence for safety outweighs the evidence for danger, the brain is going to produce less pain.
Hmm.
But when a person comes into our office and they say something like this, and I'm sure you hear people say this: "Well, I've been to the doctor, and the doctor says, you know, it's a miracle I can walk. And look at my MRI, look at my x ray. I take all these medications, and they barely touch the pain that I have, which means um, that I'm in a very bad condition, and there's nothing I can do about the pain that I have." Well, what they just said is, here's all the evidence is stacking up in this column of evidence for danger. And when you ask them, well, what evidence do you have that maybe things aren't so bleak? they don't really have any. And
Hmm.
so one of the first pieces of evidence that we tried to give them for safety is, you know what? Pain actually doesn't equal harm.
Hmm.
And motion is lotion. Pacing is progress. The brain can be rewired. MRIs don't tell you everything. Most medications for treating chronic pain don't work anyway. It's not
Hmm.
a sign that your pain is that
Yeah.
bad. That's a sign that they're really ineffective.
Yep. Yes, it
You
is.
know, and so as people begin to get that new perspective, and then we add this element that I'm talking about here, which is acceptance and the giving up of control. When you treat something that was formerly a threat to you as something that is no longer a threat, the brain says, well, why am I producing all this pain if you're not even bothered by it?
Hmm.
So um, I heard this once said to me, which was really neat. A person said, uh, "My pain level when my pain sensation when I came in and started working on this was at this level." Um, and sometimes right now my pain sensation is exactly the same as it was back then, but I no longer see it as a threat, and I wouldn't rate it as a 7. I'd rate it as a 2.
Hmm.
So
Interesting.
so really what they're doing is turning down the amplification of those sensations that they have so that it becomes something distressing.
Mm-hmm.
And if we can kind of uh, you know expand the tolerance that a person can have for some of the discomfort that they experience, you're going to increase their functioning. As you increase their functioning, as you know, they're going to do more. They're going to get better blood flow, better stretching, better strength, better core stability.
Hmm.
Um, they're going to sleep better because they're moving more. As they sleep better, they're going to,
Yeah.
have less difficulty with, sensitivity to pain. I mean, it then snowballs in a good direction.
Hmm.
And I think the snowballing that happened that led to their chronic pain, is something that's reversible. And it really starts with looking at pain differently, learning how to calm down the nervous system, learning how to get moving again, um, and being willing to take that risk of moving toward what is distressing rather than trying to control it and move away from
Hmm. Well, that's a great explanation. That really helps me a lot to unpack my understanding of pain and how that works. I'm excited to start listening to some of your podcast episodes because not only can I tell that I'm going to learn new things and it's going to help me, and I'm probably going to be sharing them with clients,
it. Good.
but I also just love listening to your voice because it seems so relaxing. I feel like you
Oh,
have a practiced voice, and it's just nice listening to you. So thank you for
well, thank you.
your mannerism. I have one question that is just been in the back of my mind for a while now, and I don't know how often you get this question, but how would you compare the work that you're doing with people to something like John Sarno's work? I'm sure you're very
Oh,
familiar with his
yeah,
work, and I know that was, one of the first doctors to really try to bring in the mind body connection and the psychology with people. But
right.
how are you kind of viewing his work, and is your work similar or different? I just want to
Sure.
get an understanding of that.
Yeah, yeah. We could probably talk quite a bit about how a person's personal history, impacts their mind, impacts their body. Because John Sarno did a very, very important job, I think, of helping people be aware that many of the difficult things that they have been through in life, whether it be in their childhood or in a recent, very abusive, difficult relationship or in a
Hmm.
terrible work setting, that has a lot to do with what's happening with us physically.
Hmm.
And So he really was able to help, I think, shed light on that. And we also understand that a person's personal history has a lot of influence over, how their stress levels are and how their body responds. I had just written an article on the impact of adverse childhood events
Hmm.
on uh, what happens to the body in that influences perception of pain. There's a direct relationship. And I think the more we understand about that, the more we can help people. So the way that we work, that's maybe a little bit different than John Sarno's, is that we feel that the tools that we give people to deal with their chronic pain and the stress that they have are tools that they can then apply to dealing with distressing memories, deal with distressing emotions, deal with difficult relationships. And so we probably focus more on uh, establishing good tools that people can use for multiple issues in their life rather than just focusing on let's talk about the difficult issues that you are coming in with your personal history.
Hmm.
So as you know, some people are quite open about talking about their background and their past and the difficult things, and some people just are not.
Hmm.
And for those people, we don't want to alienate them, by saying, "Hey, this is the direction that you're going." I think when somebody has a bit of buy-in, for John Sarno's approach, I think they're going to be helped by it.
Hmm.
But I think even if somebody doesn't have buy-in for that, I think you can still give that person tools that can help them move in that direction so that the distressing things that are in their life can be managed better.
Okay.
Does that help?
Yeah, that does help. Yeah, thanks for explaining. And I know I just bring up that point because I know that's a very famous person in terms of
Yeah.
understanding low back pain specifically, but just a lot of chronic problems and how the psychology can connect with that. So I
Yep.
know I was thinking about that in a little bit, but thank you for answering that question.
Hmm.
I'd love to know where people can get a hold of you, how they can reach
Okay.
you and learn more of your stuff. You've got your podcast. Would you just say the name of the podcast and some
Yeah.
of your
Yeah.
contact
Yeah.
info for
It's
people?
called the Pain Rehab Podcast or Pain
Pain.
Rehab Podcast.
Okay.
I have a website that's called painrehabsource.com. So the podcast is on there as well. The podcast is on iTunes.
Hmm.
And so the visualizing or physicalizing pain exercise is one of the exercises that's there as a podcast. So if you're interested specifically in that, you can kind of hear my explanation.
Okay.
And then the hospital itself has a website. Um, so my own personal website, Pain Rehab Source, is not connected to the hospital. I
Gotcha.
just want to be clear about that. And then the hospital is Mary Free Bed, um, and Mary Free Bed Rehabilitation Hospital. But the website, I believe, is maryfreebed.com.
Okay.
Yeah. And so we are able to actually see people from a number of states. People fly in. Um, well, I mean, we are under this unusual circumstances that we're not seeing people physically
Right.
right now.
Right.
Yeah, but we see people from many, many places outside of Michigan.
Okay. Well, this
Yeah.
has been fantastic. Thank you for giving me education about your work, your background, pain education. You're definitely bringing a great perspective and an approach to how you're working with people in chronic pain, things that I need to learn more about and see how I can help people with this different area as well. So I just
Hmm.
thank you for educating us in this. And I thank you for your time and being on the podcast today.
And thank you for the invitation. It's been a pleasure talking with you, Brandon.